today's discussion is actually going to go back to a topic that I think was making a few more headlines even a month plus ago. But obviously now that we're looking at the impact of what it means and how it's influencing our management of the virus is very important. And here to talk to me about it today is Dr. Pinar Karaca-Mandic. She is the academic director of the Medical Industry Leadership Institute at the University of Minnesota Carlson School of Management, also from the Department of Finance. And before we get into the topic itself, do you want to say hi, Doc?
Hi, everyone. Thanks so much for having me. Yes, we're going through really difficult days across the nation, and I'm just happy to be able to contribute a little bit of information from our study through this interview.
Yeah, and just as we were saying right offline here, obviously your proximity to a lot of troubling events that have been happening and making national headlines in the last few days, coupled with this pandemic. Just very glad to hear you're safe and well and able to do this interview. And thank you so much for joining us, Doctor.
Thank you.
Your time is especially valued right now. So thank you so much for that. And let's get into the research letter that we're discussing here. This is something that was published in JAMA just about a week ago now. Association of Stay-at-Home Orders within COVID-19 Hospitalizations in 4 states. And as I was sort of alluding to at the start here, this is a topic that probably headlined public debate back in March, honestly, when state regulations started coming out and the emphasis of social distancing began, and people kind of challenging and questioning the merits of these practices that were among the very first to come out. So, Doc, do you want to go through exactly the makeup of this trial and what exactly you found to be the most impactful findings?
Yeah, sure. Basically, exactly around the time you suggested, the beginning to mid-March, when we started looking at the data, and I'm a health economist, and I do a lot of work with data. So looking at what is the data out there on this disease, there were a lot of information about cases, but then when you look at the data on cases, the general consensus was that the cases were not really reliable because of the absence of sort of a community-wide testing, not scalable and not random testing. And a lot of people were at the same time looking at deaths, mortality, which is also very important metric, but then mortality comes with a big lag. What we were really interested in looking at is, of course, these measures were being taken at that time, with closure of the schools, the stay-at-home orders, shelter-in-place orders, and of course that's keeping people at home, but what is the impact of that and how do we measure it? And we quickly realized looking at cases were not going to be one way to figure out whether these public health measures were being effective, and then the mortality, we could look at it, but again, it would come at a very big lag. And hospitalizations, on the other hand, is a very valuable metric for assessing some of the effects of these public health interventions, especially because hospitalizations allow us to measure and figure out the impact of the disease on the healthcare infrastructure and the system, and the pressures on both in terms of the beds and the hospital space, but also staffing in terms of the clinicians and the nurses. Unfortunately, when we started looking more, that data actually did not really exist much. And that's sort of when we launched the project. The center I lead, Medical Industry Leadership Institute, joined with another center at the Carlson School called Management Information Systems Research Center. And we made a big effort to try to collect data from different states, publicly available data, in the number of hospitalizations, number of people in ICU. And when we started, very few states were actually reporting this data. So it took a little bit of engagement with the state public health departments to try to get this. In this particular study, we were able to go back to our collection efforts, and we were able to identify 4 states that actually fit the criteria we were looking at. We wanted to have enough of a period of observation before the stay-at-home order actually took an effect in the state. And then we wanted to have enough of a follow-up period. We can get into the details in a bit, but 4 states fit our criteria. And these states were Colorado, Minnesota, Ohio, and Virginia. And the study design is very simple. And we basically looked at these 4 states with a stay-at-home order, and we projected we basically fit an exponential curve. Don't get me wrong, we did a lot of other statistical analyses and fit other types of curves, but exponential curve was a very well-fitting curve explaining how hospitalizations were tracking in these states before the stay-at-home orders became effective. And then we basically said, okay, this is how an exponential curve is predicting the observed stay-at-home hospitalizations in the stay-at-home before the stay-at-home order. So now let's look at what happened to the hospitalizations after these stay-at-home orders became effective. And in 4 states, very consistent story. Immediately after the stay-at-home orders became effective, which we define as like a 12-day period after the actual date of the issue, the hospitalizations, the actual hospitalizations we were observing fell off of that exponential growth curve that would be projected. So a really clear indication that something is happening in these states that is associated with a reduction in hospitalizations with about, on average, 50% lower. So that's basically what we found in the study.
Wow, I mean, that's just really impressive. And going into it, honestly, in terms of expectations, and obviously, you know, working with the exponential curve, as you said, there is some merit to it, but of course, any kind of estimation has variables to it. What kind of anticipation did you have for what the outcomes could be?
Yeah, that's a very good question. You know, I mean, anecdotally, I think we each observed that these stay-at-home orders worked to some degree, like it kept us home, right? But at the same time, that is not really sufficient. Just knowing that is not sufficient to know, like, what is the magnitude we can expect? I mean, I think going in, I personally expected that we would see some slowdown associated with these stay-at-home orders, but the magnitude is really what we don't know. And that magnitude becomes important because the stay-at-home order is not a sustainable solution, right? As we see in many of the states, the economies have to open up, the states have to reopen. And so that understanding that link between keeping people at home and what it means for the hospitalizations as this sort of the next indicator, which will then unfortunately lead some of those hospitalizations to mortality, right? Understanding that path is really critical. So we didn't know the magnitude, I would say, but we knew that we had reasonable expectations that we would see some change in the trajectory from what would have been in the absence of these stay-at-home orders.
And what sort of factors do you think really applied to the absolute benefit that we saw? I mean, other than timeliness and just, you know, the response time to it, was there anything particular in the parameters of the observed states and their regulations pertaining to stay-at-home orders that really influenced it more?
We did not really distinguish between how strong the stay-at-home orders were and how they were enforced. And of course, we always have a study limitation that we're upfront about. We can't really say everything is due to the stay-at-home order either, right? Coming into the stay-at-home order, states closed schools in different districts. But unfortunately, these things happen much earlier than stay-at-home orders, for which we don't really have hospitalization data early enough to be able to track and separately identify how each of these separate components may have contributed to the slowdown. So we kind of just say, okay, this is what we can measure. We take it, the stay-at-home order date, and then we add a 12-day period to it, as I mentioned, which is the incubation period based on the clinical studies. That's basically about a 5-day period from infections to showing some symptoms, plus another 7-day period from symptoms to hospitalizations, what's shown in some of these other clinical work that's coming from China and other places. And so we said, okay, if you do a stay-at-home order today, it will really become effective in 12 days for us to be able to observe any hospitalization effect.